Before we start the episode, we have a very exciting announcement.
That's right, Alex. We will be recording a live episode of the podcast at Microbe from the ASM studio in the exhibit hall on June 16th at 11:45 in the morning. And I'm not going to name any names, but we'll be talking with two virology phenoms about all the hot topics that are circulating in the clinical virology field right now. So it should be fun.
I am very pleased to say that Ellie is hosting this one, so I will be sitting back and drinking coffee and making wisecracks. We would love for you to join us, and we hope to meet you there. And now, on with the show.
As many of you are likely aware, May is recognized as Women's Healthcare Month by the National Cervical Cancer Coalition, and this year the CDC has identified the week of May 14th as National Women's Health Week. And for those of you who need a reminder, May 14th is also Mother's Day this year. So what better way to recognize these national events on the podcast than to talk about diagnostics for a number of extremely common and uniquely female issues? Of course, I'm talking about infectious causes of vaginitis and vaginosis. Classically, diagnosis of these infections has been done at the point of care using wet mount microscopy and assessment for various clinical criteria, all approaches associated with some subjectivity and, let's say, imperfect performance characteristics. So as we're all well aware, molecular solutions for detection of the various pathogens associated with vaginitis and vaginosis are now increasingly available for use in clinical laboratories and at the point of care. And as is the post-COVID trend, a number of these assays, including the one that we're going to discuss today, can be performed on both clinical and patient self-collected samples. Welcome to Editors in Conversation. I'm your co-host and JCM editor, Ellie Thiel, and am joined by JCM editor-in-chief, Dr. Alex McAdam from Boston Children's Hospital. Alex, great to see you.
Great to see you too, Ellie. How are you?
I'm good. And I couldn't help but notice recently on Twitter, of course, that you spent quite a bit of time trying to figure out whether the phrase more correct or most correct was the grammatically accurate word or way of saying this is the preferred answer. And so that got me thinking, I don't know if people know this about you, but you have some very strong opinions on grammar and appropriate use of words and appropriate use of punctuation. And so were you always like this, or is this kind of a character trait that one develops as editor-in-chief of a journal?
I'm so happy right now. So let's set aside the rest of the time and we will devote ourselves to grammar. I didn't prepare specifically for this topic, except insofar as I have prepared my whole life
for this
topic. No, I've always been interested in grammar, and really it's the clear use of language rather than grammar that interests me. My mother was an English teacher. Her father was a newspaper editor. So I come by my interest in grammar honestly. And when the Twitter exchange you're talking about, I had put up something about which is correct, this, that, or the other. And somebody replied, more correct or most correct, or something along those lines. And do you remember what I said in reply to her?
No.
Instant follow. So I had to follow her, of course. The distinction is beautiful. Best I can tell, more correct and most correct are both correct. The word correct can be used in that way. And I had a long day that day, and it was very satisfying to spend some time looking into that.
So it wouldn't just be correct?
Correct is also correct.
Correct is also correct?
As is more correct, as is most correct. Correct?
Wow. Correct. Do you have any other pet peeves we should be aware of?
Well,
grammatically speaking.
We were chatting before we started about the Oxford comma, about which I have a strong opinion, but I think we should bring our guests in to talk about the Oxford comma.
Before we bring them in, does someone want to define what the Oxford comma is for those of us that maybe do not care so strongly about the Oxford comma?
When you are listing things in a sentence, you separate them each by a comma, and you separate the last one with the use of the word and. The so-called Oxford comma is one that precedes the and.
So let us truly bring in our guests today. So, Dr. Lillis.
Welcome to Grammar Talk.
Welcome to Editors in Conversation. Do you have any strong feelings on the Oxford comma?
I am in favor of the Oxford comma. I know that may be a little bit controversial, but that's just how I learned to do things and continue to do them. I like the clarity.
The clarity. Dr. Vanderpool, thoughts on the Oxford comma?
I actually think it depends. There are some times when your list needs the and, but it's part of the whole list. And so if the list is really coherent, I don't put the comma before the and. But if the list is really disparate things, then I put the comma before the and so that everybody knows that this is really a separate thing.
Okay.
It's esoteric and I can't explain it any better than that, but I have a system in my head. But I don't like the use of individuals, since by definition that is one person. So how can you have one person plural? And I don't like almost exactly, because either something is exactly or it's not, because one of those is not correct. Not even most correct or more correct.
Perfect. So Alex, what are your strong feelings on the Oxford comma?
My feeling is that the Oxford comma is over debated and a subject of far too much interest. I think that sometimes it's necessary to remove ambiguity, and then it should be used, and the rest of the time, I don't care.
Speaking of over debated,
You want to weigh in on the Oxford comma, Ellie?
I do not put a comma before my ands, so I guess I'm opposed to the Oxford comma myself.
Right.
You know what else I'm opposed to? Semicolons. I don't like semicolons either.
I know your feelings about semicolons. We've
Yes.
discussed this.
We
I'm
have.
a big fan of the semicolon.
I like
Yes.
a
It can
semicolon.
be used for clarity, and I think it can be used.
I like semicolons too. Sorry.
Oh gosh.
It can be used for clarity and for beauty in writing.
Okay, so I'm not going to win this one. But I guess all things to keep in mind for the next time we write a paper. Although personally, I will say I cannot say enough good things about the awesome copy editors we have at ASM that deal with all of these nuances for us.
They are good.
All right. So we hope that you've enjoyed previous editors and conversation episodes, and ask that you please subscribe and review them wherever you listen to your podcasts. This episode is brought to you by the Journal of Clinical Microbiology, available at jcm.asm.org and on Twitter at jclinmicro, and it's supported by the American Society for Microbiology, which publishes JCM. If you're a member of ASM, you can get up to 50% off of the publication fees when you publish in JCM or any of the ASM journals. Also, please remember that discussions on the podcast include unscripted, impromptu comments which are not meant to promote or discourage use of assays or methods. Listeners should refer to the JCM publication for all the facts and nuances of the studies that we discuss. All right, so we met them briefly, but we'll introduce them officially. Our two guests, both new to the podcast. The first is Dr. Rebecca Lillis, who is first author on the paper we will be discussing today. Dr. Lillis is an associate professor of clinical medicine at Louisiana State University Health Science Center and is the medical director of the LSU Crescent Care Sexual Health Center in New Orleans. Dr. Lillis, we're very happy to have you on today.
Thank you. I'm looking forward to it.
Great. And we're also happy to welcome Dr. Barbara Vanderpool, who is a professor of medicine and public health at the University of Alabama at Birmingham, where she directs the UAB STD Diagnostics Laboratory. Dr. Vanderpool also serves as the president of the International Society for STD Research and is chair of the upcoming STI HIV World Congress that's being held in Chicago this July. Dr. Vanderpool, welcome to the podcast as well. We're very glad that you could join us.
Thanks for having me. No more grammar today.
No more grammar. That's about my fill as well.
Let's not close that door.
Okay, so the two of you, alongside your co-authors, recently published a paper in JCM entitled Clinical Evaluation of a New Molecular Test for the Detection of Organisms Causing Vaginitis and Vaginosis, and we'll put a link to the paper in the show notes. But we're going to start with a little bit of background before we dive into your findings. So Rebecca, going to go kind of into the basics here, but can you define for us the difference between vaginitis and vaginosis, since I think these are frequently used interchangeably in practice?
Sure. So vaginitis typically refers to a condition that causes inflammation of the vagina, things like yeast infections, candida, or trichomonas. But sometimes you'll also hear bacterial vaginosis lumped in with those conditions. But vaginosis actually refers to a bacterial overgrowth. In the case of BV, it's a shift from normal, healthy, lactobacillus-dominated vaginal microbiome to overgrowth of anaerobic bacteria.
Thank you. That's helpful. So you kind of touched on it, but what organisms are we most concerned about when it comes to these processes?
Sure. So for vaginitis, inflammatory condition, we're concerned about Candida vaginitis and Trichomonas vaginalis. Bacterial vaginosis is more of a shift in the microbiome, so there's not one organism at play there. It's more of a spectrum. So the loss of the lactobacillus and the overgrowth of these anaerobic organisms.
Got it. And what about the general prevalence of these infections in the U.S.?
BV has a prevalence of about 29.2% in women aged 14 to 49. Trichomonas has a prevalence of about 2.1% in that similar age group. Candida vaginitis, it's hard to say how many cases there are because that's not really reported, but it is one of the most common reasons women present to their doctor's office. Vaginitis complaints in general, encompassing all of these things, result in about 10 million office visits a year and are the most common reason women seek medical care.
10 million.
Yeah.
Wow.
Yeah. Estimated.
Estimate, right. Could be more.
Thank you. Bobby, let's turn to you and start talking a little bit about the diagnostic testing. Many of the guidelines still include Amsel's criteria, which are criteria used at point of care, and Nugent scores for diagnosis of bacterial vaginosis. Can you refresh us on how these non-molecular approaches are performed and what concerns there are about using these methods?
Sure. So Amsel criteria relies on clinical observations, signs, and symptoms. And it's basically 4 different features. And if you have 3 of those 4, you're classified as having BV. And that involves having a high pH above 4.5, reacting with potassium hydroxide to provide or to make amine odors or that fishy odor, having clue cells on microscopy, which is when we have a lot of bacterial cells adhering to the epithelial cells, and having a milky and thin and homogeneous discharge. Problem is, we don't do all of those things anymore because we don't even always do pelvic exams. And so you don't necessarily get all 4 of those criteria. They're not great when you have 4 to choose from. And then when you have fewer, you start losing reliability. Nugent score is actually something that's done mostly in research labs, very, very rarely in clinical practice. And that's relying on a decrease in lactobacillus, an increase in the number of gram-negative curved rods, increased in the number of gram-variable bacilli, and basically it gets scored based on these 4 components and up to 10-point scoring. And it's so unreliable that during research projects to evaluate diagnostics like molecular diagnostics, generally they have to all be done in one lab because it's so subjective. And so getting those numbers to match between readers is actually quite difficult. So it's not a good routine diagnostic, and it's certainly not something that many people have the facility to do because most doctors' offices can't do gram stains anymore.
Mm-hmm. Yeah. You know, I remember learning about Amsel's criteria as a fellow, and I couldn't help but think, who in the heck came up with the fishy odor smell?
Mm-hmm.
Like, you know, what's the background on that?
Well, people were putting KOH on because it allows you to see the pseudohyphae better under the microscope. But when they would do that, they would get this face full of the stench. And actually, stench is what the S in Amsel stands for. So
interesting.
Yes, there's another grammar treat for you. But, I'm not sure stench is the word you want to have applied to you when you're in the doctor's office. But, but one of the things I will say is that you can tell that these infections can cause problems and women really have a lot of trouble dealing with because it actually impacts just your own perception of yourself because you can smell it too, obviously, right? And so they are not trivial infections, and they're not to be really minimized. And I just want to add, Dr. Lillis is right, of course, that there's about 10 million cases a year, but in studies that have looked, fewer than 25% of women even get a clinical evaluation using AMSIL's criteria.
Mm-hmm.
People just, they know they can look at the discharge and tell what it is. So they're only using one of those criteria and making a distinction that is probably not as accurate as women deserve.
Yeah. And I think the other problem is it's not a one and done type infection. It's repeat infections that are.
Well, in women that don't get treated or don't get actually diagnostic criteria performed during a clinic visit and just get treated based on whatever aspect it is that somebody made a decision, tend to come back way more often in that first 90 days. And so you have more of a burden on the healthcare system when you're not doing really accurate diagnostics.
Right. So we talked about diagnosis of bacterial vaginosis, but what about classic approaches for Candida and Trichomonas?
So again, Candida, most people look at discharge and they want to say, oh, it's curdy like cottage cheese, and so clearly it's Candida. Unfortunately, things are never really quite that simple and that straightforward. So it's not clear that you can just look at discharge and say it's Candida. People can look on the microscope if they still have access to a microscope, and they may or may not be able to see the pseudohyphae depending on how the smear looks. And then some people still do culture. And culture is a gold standard in some labs because you can still do resistance testing and you can do speciation from the culture. But in reality, most people have Candida albicans and don't really need the speciation. So having a molecular test is actually a step forward.
Yeah, and I would add too that the risk with using just eyeballing the discharge is that you're going to miss the co-infections. So yes, they may have a discharge that looks classic for a yeast infection or classic for BV, but if you're not really taking the next step and doing the full AMSILs or, sending off for a molecular test, then you may miss the people who are co-infected with another one of these organisms.
Mm-hmm.
And in a study that Jane Schwebke published in JCM several years ago, I think 2016, 2018, around in there, she showed that in mixed infection cases, clinical diagnosis falls to only about 25% accurate. So it's just not your best foot forward. And in the data that we published in the study we're talking about today, 24% of the women had mixed infections. So it's a substantial proportion. So again, thinking that you can just eyeball it, and even if you've got microscopy, sometimes one bug is so common in the microscope, you don't see the other bugs, they're masked. So, it can be problematic.
Right.
This is very sobering about the use of these phenotypic and culture tests. Bobby, do you have any sense of how frequently these tests are used in the United States?
Well, like I said, only about 25% of women get a clinical evaluation. Very few get yeast cultures because most labs don't do it anymore. I mean, very large reference labs will do it, but most labs don't do it anymore. And so it really is mostly just patient report and looking at the discharge, and that's what you're getting for your diagnostics.
So, Rebecca, in an effort to kind of obviate all of these limitations that you and Bobby nicely described, we're increasingly relying on molecular assays for detection of these pathogens. So that kind of brings us to your study. Can you tell us about the overall goal of the study and talk about what assay you guys evaluated and generally how the platform compares to some of the other common BV, CV, Trich molecular assays out there?
Sure. So the assay we evaluated was the Cepheid Expert Express MVP, and it's designed for use on Cepheid's Gene Expert systems. It's an automated qualitative diagnostic test for the detection of DNA targets from anaerobic bacteria associated with BV, Candida species associated with Candida vaginitis, and Trichomonas vaginalis from vaginal swab specimens. During the study, we also evaluated whether those swabs could come from either a patient-collected specimen in a clinical setting or a clinician-collected specimen and compare how those tests resulted from each of one of those types. We also evaluated the performance of the test in the near patient or point-of-care setting with untrained operators to lab-based testing. So the goal of the study, the comparator test we used, was the BD Max vaginitis panel for BV, We used yeast cultures followed by the MALDI-TOF for Candida and the BD Max vaginitis panel plus trick culture for TB. So if either one of those, the vaginitis panel or the trick culture was positive, they were considered positive. So I think that's pretty much it. I could go on. Maybe I should stop.
That's a complicated one.
Yeah. There's a lot of moving parts here.
So as we've been discussing, this was not a simple study, and it was not a head-to-head comparison at a single site.
Right.
Bobby, can you tell us the study design and talk about the enrollment criteria for the study?
Sure. The enrollment criteria were quite simple. You had to be 14 years or older, depending on the regulations and the jurisdiction enrolling. And you had to be presenting with signs or symptoms that are consistent with having vaginitis. So some sort of discharge, pain on urination, so on and so forth, pelvic pain. So other than that, there was no restrictions. And so there were no restrictions about antibiotic use because we know that, for example, women who've been on antibiotics might have a yeast overgrowth. And when I say yeast overgrowth, it's so hard. We want to say yeast infection, but of course it's a commensal organism, right? And so it's not really an infection, is it? It really is an overgrowth. And that tends to be the problem with all of these things, is that a lot of what's going on is a dysbiosis and a misregulation and a difference in the abundance of the different bugs. And so it makes it really hard to have a diagnostic that it's not just present or absent. I mean, like when we look, for example, let's say even trichomonas is pretty straightforward, right? Because trick is either there or it's not there. And if it's there, it's pathogenic and needs to be treated. But the same is not true in the case of BV or even Candida. And so that's what these tests really have to work hard to demonstrate that a woman has not just the organism, but has disease from the organism, and that the assay's results correlate only to disease and not to commensals. So that's where the trick lies in all of this.
And if I could add that the assay that Cepheid has for their BV call-out targets, they're just looking at organisms associated with BV. So other panels that are FDA approved, like the Aptima panel and the BD Max panel, they have more of a formula in there for the amount of lactobacillus versus the amount of the BV-associated bacteria. But with the Cepheid assay, they were just looking at BV-associated bacteria 2, Adipobium vaginae, and Megasphaera 1 in their assay. Nothing that should be really found in abundance in women with normal vaginal flora.
Which is really interesting when you think about it, because many people, when they hear BV, they instantly think Gardnerella. Gardnerella is not a target of this assay.
Yeah, because it can be found in normal, healthy vaginal microbiome.
Right. So it was an interesting approach. It was a little bit different.
Yeah. So I think we'll talk a little bit more about that when we get into the actual results. So we might have you kind of summarize some of the nuances there between the assays again. But Bobby, kind of going back to the initial setup, one of the goals was to assess performance of both self-collected and clinician-collected swabs. So can you talk about the swab collection process and summarize for us? Well, I guess, Rebecca, you kind of summarized what the comparator assays were. But Bobby, if you could take us through how many swabs you collected and what they were used for.
Sure. And I'm going to take one step back and actually finish answering the question that I skipped over before. But that is that there were 12 sites in this study, so it was a multi-site study. And I think Rebecca mentioned in passing sort of that they were trying to get claims for CLIA waiver, so this could be used in point-of-care testing in CLIA-waived settings. So they had 9 of the 12 sites doing the testing near the patient. And then the other sites were lab-trained folks, whether they were in a lab that was near the patient or in a reference lab. So that part of it was also a comparison. And then they were comparing self-collected to clinician-collected. I've been working in this field of sexual health for a very long time, and we started promoting self-collection of vaginal swabs for STI testing back in the late 1990s. So it's not new. But, everybody's finally figured out that, hey, we can actually increase the efficiency of clinic time by letting women self-collect their samples, before they start interacting with the provider. So in this study, what they did was they had the patient collect her own sample. And after she did that, then there were 5 more samples collected by clinicians. And those samples were used for the comparison head-to-head with BV. One was used BD, the Max vaginal panel assay, and one was used for yeast culture. One was used for the Aptima in case there was a backup, and then there was another one on the expert again. So you had head-to-head expert clinician collected versus expert self-collected. And, the self-collection is really, all women know where their vagina is. That's just a thing. It's we know from a very early age where it is and pretty much know how to put things in there. So getting the samples is really not much of a trick, but of course they do provide instructions for women to follow, step by step. Wash your hands, do this, do that, take this swab, swirl it around, the vaginal walls 3 or 4 times, put it back in this tube, so on and so forth. And those kind of instructions come with the test because eventually one could imagine that these may be over-the-counter tests.
Bobby, can you tell us what approach you took to discordant or discrepant resolution when you were doing the analysis of the performance of the test?
Right. So these tests are hard to evaluate because since you're comparing molecular testing as well as in some cases culture, you have very different methods and you have very different sensitivity estimates in general. So for this test, if the BD or the BV result did not match between the expert and the BD Max assay, then the Aptima BB assay was run. If the culture for yeast didn't match with the results from the expert assay, then the BD vaginitis panel yeast part of the test was used for the results to adjudicate those discordants. And then finally, for those that had a trick inconsistency, the Aptima trick assay was run. So there were a lot of moving parts because there were a lot of different comparators for every single thing that was done. So a lot of data to collate in the end.
Thank you. And Rebecca, let's start talking about the data a little bit. Can you summarize for us how many patients were enrolled and tested, and a little bit about the demographics of the patients?
Sure. So over the 12 sites, there was 1,488 participants enrolled, resulting in 1,478 evaluable subjects. Now, not all of those had results on every target, but they used what they could from each subject. 38.9% of the participants were between the ages of 18 and 29 years. The racial makeup of the enrollment population was 56.4% white and 39.2% Black. 15% of the enrolled population was Hispanic. Interestingly, 50% of the women enrolled reported a history of BV prior to their enrollment in the study, meaning a prior episode.
Thank you. So, Bobby, starting with the BB target, can you tell us how the MVP assay performed for both self and clinician collected swabs relative to the BD Max vaginal panel?
It performed very well. It had sensitivity of 93.8% for clinician collected swabs and 94.1% for self-collected swabs. This is something that we see a lot, is that the swabs have a tendency to be a little bit higher quality when the patients collect them themselves. I think maybe they're more assertive or aggressive about really getting a good quality sample because they're kind of nervous that they really need to sample, so they maybe oversample. But yeah, the agreement was really great, both between the two tests and between the two sample collection types.
And among the discordant results then, how did they separate out when you tested them, or on the Aptima assay, I should say?
So the discordant results, it was kind of interesting, and I would refer the reader to table 4 in the manuscript because it's actually quite complex. But what happened is when you go through and redo all of the discordants, what you find is that the vast majority of them, like about 50% confirmed and 50% didn't. But that means that 50% of the Aptima agreed with the express assay that we were testing, and 50% agreed with the BD Max. So now which one's right? And the thing is that you don't know, and I think that's why it's important to go back to what Rebecca said a little earlier. These assays all have slightly different targets and slightly different mechanisms for analyzing the results. So for example, the BD Max assay includes Prevotella species, it includes Gardnerella, and those are not in either the expert assay that we were evaluating or in the hologic assay. So the hologic assay has Gardnerella and Megasphere and BVAB2, but it doesn't have all the others. And both the Aptima assay and the BD assay have an bioinformatic calculation to look at relative abundance because they include detection of lactobacillus. So they're mimicking that AMSL criteria and the Nugent score where you're looking for a decrease in lactobacilli, right? And they're doing that informatically with a relative abundance. So they're showing that these other bugs like Gardnerella have overgrown that lactobacillus. The expert assay is not doing that. Mm-hmm. And I think that explains why you get these slightly different results amongst all of them. And so if you had a perfect test in a perfect world, you might pick up all of those with one test, but I think that we're seeing where the wiggle room is.
Right. The nuances between the individual methods and assays. That makes sense.
Just BV is just so complicated, you can't really make it that simple. It's
right.
Like to.
Rebecca, let's turn to the performance of the candidate targets in the assay. What was the agreements between self-collected and clinician-collected swabs tested by the MVP assay compared to yeast culture with MALDI ID?
It was very, very high. So the positive percent agreement for the clinician-collected vaginal swab was 98%. For the self-collected, it was 97.5%. And the negative percent agreement was 94.6% for clinician and 92.1% for the self. Then for the Candida glabrata krusei call out, it was pretty similar to 93.6% on the fresh specimens for positive percent agreement and 97.8% on the self-collected.
Thank you. And let me follow up on that a little bit. Regarding the Candida culture positive, MVP and BD negative samples, were any of the recovered isolates not targeted by those two assays? Or do you think it's an issue with the order in which swabs are collected for testing?
Some of it may be the swab order. So the patient collected specimen was always first, and then they randomized the next 4, which was, so you don't know where the clinician collected Candida came in for the Cepheid test versus the BD test. Now, the Aptima test as the comparator was always the last clinician collected swab. So that one would have potentially the least material on it. It was not reported that there were any Candida species that were not part of the targets for the Cepheid assay. So it could be something to do with collection. Also, the method of yeast culture was an e-swab and then sent to a reference lab. So it's always potential that something could have been contaminated along the way.
But as we mentioned earlier, since Candida albicans is a commensal, you do have to set a cutoff. And like anything else, you're going to have sort of a receiver-operated curve where you're making your best guess about where that cutoff will be the most sensitive and the most specific. But you know that, again, it's never going to hit perfection. And I think that those culture-positive, assay-negative, molecular assay-negative samples are probably an illustration of where they've been a little bit conservative in that cutoff, trying to avoid false positives. And so they're giving up a little bit in their sensitivity, if that makes sense.
Yep.
Makes sense. Great point.
So we don't want to leave out Trichomonas. So Rebecca, can you tell us about how the MVP assay performed for that target relative to both the BV molecular assay and culture?
Sure. So keep in mind that a positive was considered positive on either the BD Max vaginitis panel or the trick culture. So we weren't comparing those separately. And if the patient, the MVP had a positive percent agreement of 97.3% on both types of swab specimens and a negative percent agreement of nearly 100%. So it did very well. Interestingly, I was looking at the discordant results, and the Aptima test for those that tested one way or the other, it was incorrect for the Cepheid panel. About 3/4 of them agreed, the Aptima agreed the Cepheid, not the reference method we used. So interesting. That table that Bobby referred to is very interesting if you get down into all the footnotes. It's got like 12 or 15 footnotes. But
yeah, it does.
It's got an impressive.
But they're all needed.
The thing is that this is sort of a holdover, as molecular tests developed for things like chlamydia and gonorrhea. We went through all of this where we had to do culture or we had to do other non-molecular methods to try and confirm that positives were true. And the reality is that when you're using less sensitive methods, then you're always going to push things artificially toward false positives. So I always tell people that I think these estimates are conservative because I think the reality is that they're compared to something that's relatively flawed. And for example, with Trichomonas culture, I've done studies years and years ago now showing that culture is probably only about 40 to 50% as sensitive as a molecular diagnostic. So the fact that we still use that in assay comparison really just kind of shows you that some of the methods that are either required by the FDA or have just become the norm for these evaluations maybe aren't the best way to do that. And as we get more and more molecular tests, we have to just keep comparing them head to head, I think.
That's a massive difference in sensitivity.
Mm-hmm.
Bobby, you also looked at the concordance between multiple infections for both the clinician and the self-collected samples. How did that look?
Yeah, and the concordance again was great. It was in the high 90s. And so even when you have these mixed infections, you were picking up the things that were in both patients at the same time. And so as a general rule, that was a good way to go. So I think that this just reinforces, if again we look at this population, 24% of the population had mixed infections. And so knowing that these assays work in that environment, I think is really important. And that's part of why it's nice that we had those data to be able to share.
Mm-hmm. Thank you. So, Rebecca, one of the nice aspects of this study was that you compared MVP results that were acquired at the point of care by untrained users to results from laboratory-based testing performed by trained users, as you stated. So did you find any differences in the results between those two settings?
No, the clinical performance was similar across the user types. And that is one thing that's very exciting as a clinician who regularly performs microscopy, to think that you might be able to use a test like this in your clinic, have reliable results within less than an hour, and not have to, worry about who messed up your microscope settings or being out of KOH or, all the different little aspects that make microscopy so burdensome. Mm-hmm. And I should add, the test is not yet FDA cleared for point of care use, but the company expects to have that designation within maybe another 12 months or so. I checked back with them for this to make sure.
Sounds good.
Thank you, Rebecca. Bobby, overall, it seems like the Expert MVP assay performs pretty comparably to other commercially available platforms, with the added benefit that it has this potential for point of care use. Are there drawbacks or limitations with respect to the assay that listeners should be aware of?
Like anything else, again, they've had to set their cutoffs, and they maybe have tried to be conservative. And so, if you have a patient and you really think something's going on and that that's not the result you get, well, then like any other lab-based test, you should question it and use your clinical judgment as opposed to going strictly. Because every test has its little imperfections. I would add, though, that one thing that we've not touched on that I really feel strongly about is that these vaginal panel molecular tests really afford us the opportunity to provide comprehensive healthcare for women, because we've looked in women who present with causes of vaginitis to primary care, family planning clinics, and so on and so forth. About 15% of them will have an STI. So this allows us to use that same sample in that same bit of liquid and run a full panel of diagnostics on a woman, and really not prejudge women and say these women must have an STI and those women must have vaginosis. But we don't know. Let's just test them all, mm-hmm. and let's find out what's going on in these women so we can give them the best care possible. And I think to me that's the huge advantage. And the disadvantage is no different than any lab-based test that we have now. So that's a good thing.
Yeah, agreed. That comprehensive healthcare is definitely a goal that we should be striving towards. So before we wrap up, between Bobby and Rebecca, you guys have both published quite extensively in the STI, STD world. So I'm kind of curious, Rebecca, we'll start with you. What do you see as the next big advancement or move in the field? And what should labs be thinking about in this, female healthcare arena?
Sure. I think one of the things that's coming out and all the companies are moving forward with is point of care trials for diagnostics for STIs. And then after that, I think the next big development will be home testing. And whether that's running your own PCR at home on an instrument or sending a self-collected specimen in somewhere to be tested. I think that those things really need to happen just to bring the testing to the patients in a setting where they're most comfortable. Not everybody can take time off of work and get to a doctor's visit, but hopefully more home testing and point of care tests will improve access to care.
Mm-hmm. Bobby?
Well, Rebecca said it brilliantly. I mean, I think anything that improves access to care is wonderful. I think one of the exciting things is that a lot of people that made COVID tests, especially the home use tests, are thinking about rolling into STIs and women's health. And that's really exciting because these are companies that have already figured out how to work with swabs. So the vaginal swab is going to work great. Women can collect their own swabs. So everything's really just poised to let us leap into the future and really, really start letting women take control of their own sexual and reproductive health. And I think that's exciting.
Mm-hmm. Really well said. Thank you both. So it's been a really fun discussion. Thank you, Rebecca and Bobby, for joining us and sharing your expertise with us today.
You're welcome.
Alex, great to see you as always. Look forward to seeing what topic we will cover next month. Although maybe it's going to be AST. What do you think?
It could be AST, it could be grammar. We'll just have to see.
We'll have to wait and see. And thank you, everyone, for listening to this edition of Editors in Conversation.